and welcome to #OurDocTalk. This is NorthBay Healthcare's effort to connect our providers with the community. I'm Robin Miller, social media and online specialist with NorthBay Healthcare. With me today is Dr. Munzer Al-Saman, a board-certified gastroenterologist with NorthBay Healthcare. Dr. Al-Saman is a graduate of Aleppo University Medical School. He interned and completed his residency at Texas Tech University Health Sciences Center in El Paso, Texas, and served fellowships in infectious disease at David Geffen School of Medicine in Los Angeles and gastroenterology at Tulane University School of Medicine in New Orleans, or as they say in Louisiana, New Orleans. I want to thank you, Dr. Al-Saman, for taking the time to do this today.
Oh, thank you, Robin. Thank you. Happy to do it.
So we are in the midst of Colorectal Cancer Awareness Month.
Right.
So our discussion today is going to focus a lot on gastroenterology and the colon and diagnosing colon cancer and treating it. So let's start with the first basic question, which is, what is a gastroenterologist? What type of issues do you treat and diagnose?
So gastroenterologist is an internal medicine doctor who is specialized in gastroenterology or specialized in the GI tract. So the gastroenterologists deal with all diseases of the GI tract, the esophagus, the stomach, the intestine, the liver, the pancreas, the colon, the rectum. So that's the specialty of gastroenterology. It requires extra training after internal medicine training.
And so you might deal with problems of the liver or the pancreas, or it's not just get them in here for a colonoscopy.
Yeah, no, the whole GI tract. So the GI tract include the esophagus, stomach, small intestine, colon, pancreas, and liver and rectum.
So what is colon cancer?
So colon cancer is a very common cancer. It's like breast cancer and prostate cancer and lung cancer, one of the common cancer that we encounter. It's a malignant tumor of the colon and the rectum.
And please explain the difference. What do they mean by the bowel versus the colon versus intestines? These terms kind of sometimes get interchanged.
So bowel is the general term for the GI tract, which usually include the small intestine and the large intestine. The intestine is also a big term, like bowel. It's colon and intestine.
What is
now
the colon?
We have the colon is the large intestine. So after the stomach, you have a long tube that absorbs the food that we eat. That's called the small intestine. And then when all the food is absorbed, everything is dumped into the large intestine, which another tube that is not as long, but it's wider. And it's mostly manage the stool and the water. That's called the colon. So you have a long intestine that absorbs the food, that's called the small intestine, and a shorter, thicker intestine, that's wider intestine, that absorb the water and create the stool that is called the colon.
And colon cancer is tumors within the colon?
So exactly. So that's a malignant tumor inside the colon or the rectum.
So what is a polyp, or there's another, adenomas?
Adenomas.
Adenomas. What is that?
So a polyp is a tumor of the colon, very common tumor. We see it up to half of our patients when we do colonoscopies. Some of these polyps are completely benign. Some of them are precancerous, meaning if you leave them long enough, they could turn into cancer, and that's the adenomas. So adenomas are precancerous polyps. So when you say adenomas, you're talking about the polyps, but they are precancers. They are the precursors of colon cancer. So if you leave them long enough, they will turn into colon cancer. Usually, study showed 7 to 10 years is the possible time limit for these polyps to turn into cancer.
Okay.
Not all of them will turn into cancer, though. We don't know exactly the details, but in general, some of them between 7 and 10 years they could turn into cancer. Some of them they shrink sometimes, or they stay the same size.
And what do you do about them?
So usually in colonoscopy, that's the purpose of doing screening colonoscopy. So when we screen the colon for colon cancer with a procedure called colonoscopy, where we pass a tube with a camera into the colon while the patient is sedated, if we see these polyps, we remove them because we assume that they are precancerous and they could turn into colon cancer. So that's this kind of preventive medicine to prevent colon cancer from developing. So most of them are small, less than a centimeter, meaning half an inch, and they're relatively simple to remove.
And then you test them to see if they're precancerous?
So we'll send them to pathology, and then the pathologist will confirm if they are the benign type or the precancerous type.
And if they're precancerous, is there something more that's done after they're removed during the colonoscopy?
Good question, Robin. Very good question. So if you have a colon polyp, if you end up having colon polyp on colonoscopy, then you are likely at a higher risk to develop colon cancer, and you probably have the gene that could make colon cancer, and you'll need more colonoscopy, more often colonoscopy. You need what we call surveillance colonoscopy every 3 to 5 years. So whenever a patient has a polyp in their colon, that means they're at a higher risk. They're in a different category now of colon cancer prevention. They need surveillance colonoscopy every 3 to 5 years. While if you have no polyps at all and your colon was clean and the gastroenterologist felt that they saw the colon very well and there were no polyp, then the next colonoscopy, screening colonoscopy, will be in 10 years, not in 3 to 5.
How often should how old should they be when they first start getting a colonoscopy?
So usually we recommend screening colonoscopy at age 50 and in African American at age 45. And it needs to be done every 10 years.
Okay.
If you have family history of colon cancer, we start earlier, most of the time around age 40.
Okay. Let's be honest. Most people hear colonoscopy and they don't jump
They
up
run
and down
away.
and go,
Yeah.
yay!
Right.
What do you tell your patients who are worried that, does it hurt? Is there after effects of this? How do you convince them that this is an important thing for them?
Right. Well, colon cancer is very common, and it's not very difficult to convince the patient that colon cancer is a serious disease and needs some kind of monitoring and some kind of screening test. The procedure itself is not that hard. It's very short and it's done under sedation, and the majority of patients don't remember anything about it, and it's painless. The prep, the day before, you need to clean your colon. So you could imagine the colon usually has a lot of stools. So without cleaning it, there's no point of taking a look because we'll be missing everything. So it needs to be completely cleaned up. And that's the harder process, where the day before you go on clean liquid diet and you'll be taking some laxative to flush everything clean. So that's not an easy process, but it's one day. You'll have it done. The procedure itself is very simple. It's under sedation, pretty safe. Complications are extremely rare. Less than 1 in 1,000 patient will have a serious complication, and it takes around 15 to 20 minutes. And as I say, there's in most patients they won't remember anything. Mm-hmm. It's painless, and it's definitely worth it. You're preventing colon cancer by catching these polyps at very early stage and removing them before they become a serious problem.
What's the typical treatment for colon cancer? And you wouldn't do any kind of surgery or treatment. They would go to an oncologist?
Right. They will go to an oncologist and to a surgeon. So the treatment usually requires more than one doctor. So the gastroenterologist will make the diagnosis, and then the surgeon will remove the cancer, and the oncologist, which is the cancer doctor, will see after the cancer is removed. Will see if the patient will require chemotherapy, or in rectal cancer might be radiation therapy.
Okay. And again, you would team with an oncologist for that?
Yes, an oncologist and a surgeon. So you need a surgeon to remove it, and an oncologist to manage the chemotherapy and radiation if it's needed.
Can you tell us, what is colitis? And does having colitis increase your risk for developing colon cancer?
So colitis is a big term that means inflammation of the colon. So colitis could be related to an infection. you eat a burger that is not cooked well or food that is not clean, and you get a bug in your gut and cause inflammation and infection of your colon, and that's called colitis. So colitis is the big word that means inflammation of the colon. So it could be an infection, or it could be autoimmune problem. This is the disease that you hear about, ulcerative colitis and Crohn's disease. These are type of colitis.
I was going to ask you, what is Crohn's disease? I read
these
a lot about it online.
So these are inflammatory bowel disease, meaning you have inflammation in the colon and the small bowel, and sometimes in both the colon and the small bowel. The cause of it is autoimmune, meaning the immune system is attacking this organ and causing the inflammation. So that's another cause of colitis. So you have infection cause, you have autoimmune cause, which is under the umbrella of inflammatory bowel disease, and then you have sometimes what we call ischemic cause, where the gut doesn't get enough blood and get inflamed because of that. That's called ischemic colitis.
Are any of these problems an indicator or a risk factor for colon cancer?
Yes, inflammatory bowel disease. So inflammatory bowel disease, ulcerative colitis, and Crohn's disease are risk factor for colon cancer. After you have these diseases for more than 7 to 10 years, then risk of colon cancer start to creep up.
Okay. And inflammatory bowel disease, they usually call it IBD.
Yes,
they abbreviate
IBD.
it.
Yep, that's
Okay.
what it is.
What's-
So IBD is an umbrella for Crohn's disease and ulcerative colitis. Since both diseases are very similar in management, their prognosis is different, but the treatment and the cause is very similar.
And a lot of it, the treatment for those is watching diet, or are there medicines that you take?
Some of it diet, but most of it is medications. Yes, anti-inflammatory medication, from simple anti-inflammatory medication to very strong anti-inflammatory medication that suppress the immune system. That is called metabolics, and you probably see all that kind of advertisement on TV, like a Humira. Those are very strong immunosuppressive therapy that are very helpful in the management of Crohn's disease and ulcerative colitis. They slow down the inflammation of the gut by suppressing the immune system.
What are common risk factors for colon cancer?
So the most important risk factor for colon cancer is genetics. So if you have a family history of colon cancer, it's very important to check your colon. There are other risks. Some of it are probably expected, like if you're a smoker, heavy smoker, you increase your risk to a lot of cancer, including colon cancer. Too much alcohol. If you drink more than a couple of drinks of alcohol a day, you're increasing your risk to develop a lot of cancer, including colon cancer. Diet might be a factor, especially red meat. So there's some studies showed red meat, a diet that is rich in red meat, increase your risk to develop colon cancer. So I would say we should all slow down on eating red meat, maybe to once a week. Obesity could be a risk factor for colon cancer. So healthy living will definitely help prevent colon cancer.
This sounds a lot like other cancers you hear about.
That's true.
The
That's
same,
very true.
breast cancer or whatever.
The same true, like lung cancer, breast cancer.
Mm-hmm.
Yeah.
What are the different types of screening? Is it only a colonoscopy that can tell you if you're having a problem, or are there other things you can do?
There are a lot of ways to screen for colon cancer, and all ways are good. Every other way is good. The key is that if you're above 50 or 45, or if you have family history of colon cancer, you need to check your colon for colon cancer. So there are simple tests like checking for blood in the stool. It's called FIT test, F-I-T test. That's a good test, simple, and pretty sensitive. If you have cancer or if you have tumor, it will pick it up. And then you have the other spectrum is an invasive test, but is the gold standard. It's called colonoscopy, where you pass a camera and take a look into the colon, and if you see polyp, you remove it. So any test is good. It's all depend on the patient and your physician, your primary care doctor. So you talk to your doctor and tell them, I'm interested to screen my colon for colon cancer because I think I'm at the right age. And your primary care doctor will go over all the possible tests, and whatever you choose is good. Just do it. Just do some kind of screening test for colon cancer.
Now, in researching questions to ask you during this chat. I noticed that a lot of people are under the misconception that men are more at risk than women. Is that true?
No, both men and women are at risk for colon cancer.
It attacks them equally.
Yeah,
And it's not just older men.
Not only older men. Unfortunately, colon cancer is becoming more common in younger population. Now we're diagnosing colon cancer in late 40s. Not very clear why this shift. With doing colonoscopy, the incidence of colon cancer has been coming down slowly. So over the last 10 years, the incidence of colon cancer has been dropping down. Part of it because we're screening more patients. We're doing more colonoscopy. But there's a new factor that we can't really explain, that colon cancer is creeping up a little bit at earlier age. It could be diet, could be the diet that we eat, a younger generation, but we're not very clear of the cause of that surge in younger population with colon cancer.
Does removing a polyp mean you will never develop cancer?
Well, if you keep on removing polyps, very likely you will probably never develop colon cancer.
Okay. And how long after a colonoscopy will results be available? In other words, you remove a polyp and it's going to be tested.
Usually, pathology will be available within a week, 1 week.
Okay.
So theoretically, colon cancer is we could eradicate it completely if we check every single person and remove every single polyp. But that's obviously just an idea. But to apply it is very hard because sometimes the procedure is not perfect. The colon might not be completely clean. A polyp could get missed, or we can't get all the way to the colon. Most importantly, a lot of patients just don't choose not to do any test for colon cancer screening.
Okay. What can somebody do to reduce their risk besides just the colonoscopy?
Right. So healthy living is very important. Don't smoke. Keep your weight healthy. Increase your intake of vegetables and fruit because that's probably protective. Cut down on eating red meat. Don't overdo it with alcohol. Exercise. Slow down stress. Sleep well. So all the good things in life, if you could do it. Yeah.
Now, we've talked before about the Pillcam. Can you tell me, does that take the place of a colonoscopy, or what does it do? How does it
No,
work?
Pillcam, the one that's available at NorthBay is the small bowel Pillcam. So it's mostly to check the small bowel, not the colon.
Explain what it is.
So it's like a little capsule as big as a vitamin pill that has a small camera. The patient swallow it down, and it travel into the small intestine and takes picture of the small intestine, like 4 pictures per second. And all these pictures will be stored in small pager that the patient will be carrying over 8 hours during the test. And then we download all this picture in the computer, and the physician will take a look at them and see if there's any lesions in the small bowel. So it will show the small bowel. You could imagine the small bowel is like more than 20 feet in length. It's not like the colon. The colon is like 4 feet. The small bowel is very long. So for a long time, we didn't really have any way to, if we're suspecting small bowel disease, we don't have any way to see it except x-rays. So the Pillcam is a very good way to actually see it. It's like a scope, but it's free, moving by itself. It's pushed by the peristalsis of the small intestine. Now there is a Pillcam for the colon, but it's not really studied very well, and unfortunately, it's not that good to check for colon cancer. So that's why it's not popular. We don't use it very often because it's not very helpful to look for polyps. Possibly because the colon lumen is too big, so it's probably be flipping around it, while the small intestine lumen is relatively small. So let's go straight.
How big a part of the practice here at NorthBay is colon cancer screening and colonoscopy? Is that the main focus here, or do you see?
No, we see a lot of other diseases, from acid reflux to peptic ulcer disease to pancreatic problem to gallbladder disease to different hepatitis, including hepatitis C and hepatitis B, to other functional disorder of the GI tract, including irritable bowel syndrome. but screening of colon cancer and surveillance of the colon because of polyps and family history of colon cancer, screening for family history of colon cancer are a big part of our practice.
So, again, if I'm a patient and I'm a little worried about this idea of getting a colonoscopy, what's your one argument to say, get over
Well,
it?
it's a life-saving, for sure. For sure, it's a life-saving. Few times I diagnosed colon cancer on the spot in patients who have no symptoms. And it's not as difficult as you think. The procedure is simple. There's a lot of improvement in the scope that we use. The prep is becoming much easier. The procedure is short, safe, and it's could save your life.
Okay. I think that's about all the questions I have for those.
Thank you, Robin.
Just so you know, there's been a little love fest going on here on Facebook with people
that's
telling
nice.
everybody
That's
how
nice.
wonderful you are.
Well,
So
thank you for everybody.
Yeah.
Thank you for everybody, and hi for everybody. And hopefully we'll see you soon. You don't need to see me fine, you know. Hi to everybody, and thank you for all the comment, the nice comment. Happy to. I've been in the community for many years, close to 20 years. So I'm very happy here, and really just serving the community is a great pleasure of mine. Thank you.
thank you.